Hello, and thank you for allowing me to present today. My name is Hao. I am your occupational therapist. You might be experiencing this session in different formats. Perhaps you are listening to it as a podcast episode, or maybe you are attending it as a presentation. Whatever the platform, I sincerely thank you for being here and giving me your time and attention. The topic that I want to explore today is competency, specifically occupational therapy competency when working with patients who are receiving extracorporeal life support, more commonly referred to as ECMO, that's ECMO, and it stands for extracorporeal membrane oxygenation. Let us begin with the word itself, competency. What does it mean in our context? Competency isn't about just processing a checklist of skills. It's not about holding on to textbook knowledge. It's about our ability to consistently and effectively deliver care in a specialized, often highly challenging environment. In the case of ECMO and ECMO competency, competency involves having the clinical knowledge, having the technical awareness, and most importantly, the professional judgment that is required to safely practice occupational therapy meaningfully with a population that is extremely vulnerable and very fragile in terms of medical status. In many discussions I've had with fellow occupational therapists, especially those who are beginning to work in ECMO environment, there is often a lot of anxiety. There is a certain degree of anxiety and uncertainty, and that's understandable. Many of us turn to colleagues in other disciplines for our competencies with regard to ECMO, especially competencies that are borrowed from physiotherapy, for models and for templates on the things that we needed to do. There's a lot of borrowing of information, the tools, the frameworks. This is not bad. It's not inherently bad, guys. In fact, it's a sign of professional humility and the willingness to collaborate. But there is a catch. We must ensure that the knowledge we're borrowing is aligning with our professional scope. Much of the competency guidance out there that I've been looking at leans heavily on the physiological parameters, and it leans on the medical stabilization criteria. And while we need to understand these things, they are not the core of what we do as occupational therapists. Competency is very simple. There's only three things. There's a triad of competency. There are three pillars or triad. And these are the triad of assessment, planning, goal setting, and treatment planning, yeah, and actual delivery of the intervention. Only three things. These are the only three things. When I say assessment, I meant our ability to identify the needs of our patients, the limitations of our patients, their capacities, and their goals. So that's assessment. When it comes to planning and addressing the intervention or planning our intervention, goal setting, developing tailored treatment approaches, and anticipating changes or challenges. So these are the things that we need to do. That's a skill, that's a competency. Another thing, on the other hand, is the actual implementation of occupational therapy. Therapy that is meaningful, a therapy where a person would be responsive and is person centered. These three pillars are not isolated stages. They are interwoven. It's not one step after another and after another. They are linked. Each of these pillar will inform the other, and the three must be grounded in an understanding of our scope of practice, the scope of occupational therapy. We need to stay grounded. Let's talk about the scope. Like I said earlier on, there is often a temptation, especially with the complex environments like intensive care. And there is a temptation for us to do more than the things that we are supposed to do in terms of competency, learning about adjusting the settings, how to manage the sweep, how do you touch the oxygen dial, or even to help with cannula positioning. I've read this. There are situations where the competency of occupational therapists will involve these things. But I want to say this to you guys clearly. Those are not occupational therapy tasks. They are essential tasks. I understand. Yes, and I agree with that. But they fall on the responsibility of colleagues. They fall on the responsibility of other MDT members, like the perfusionists, the ICU nurses, intensive, unless specifically negotiated and institutionalized as part of the new role of occupational therapy. OTs should not be involved in the manipulation of ECMO machinery or our patient cannulation protocols. It is not the skill, it is not the scope of occupational therapists. And doing so would mean that we are breaking away from our identity, from our role. As occupational therapists, our focus should remain on human experience, the occupational perspective, the functional trajectory of our clients. When we're working with ECMO patients, our assessment competencies should always include our ability to assess a person's ADL activity or their ADL engagement, even if we need to just establish their baseline ability, that should always be given. We should always know that's an essential, very basic foundation skills that we need to do. Very simple. Even if the patient is at full level of dependency, knowing the foundation ADL abilities is where we are going to get the person back to. So don't forget about their ADLs. The other thing that we need to establish is the person's value, their occupational interests, and we can do this through structured or through informal interview. And those interviews that we do with our clients, that can be counted as an intervention on its own because it's supportive. It is a supportive intervention. Having that conversation while we're trying to find out what the person likes and dislikes, you are already establishing a person's ability. You're already establishing what they value. So it's becoming a treatment at the same time. Like I said, these pillars of assessment and intervention and treatment planning, they're all interwoven. Exploring the patient's sense of self, their purpose, what their goals are for recovery, these are all important and these are all part of our assessment competency. Even when the patient is sedated or when they are minimally responsive, they have a life story. They have a future. They have a context. And this is our role as occupational therapists to understand that context. And we need to integrate it into the care of our patients. And we can only integrate it into our future interventions by knowing it first. We must understand that ECMO is a context, it's a situation. We should not see ECMO as the definition of these patients. And most of the time, because it's a specialized tool, we are always looking at it in the sense that it is the thing. It's not. It's only a context. It's not the person's identity. It's an adaptive tool. Remember that patients with ECMO is in a temporally defined situation. It is an acute, life threatening phase of the condition, but they are still the person underneath those devices. They still have roles. They had their routines, their environments where they move, their aspirations that exist beyond their time on ECMO. In a sense, the domain of our concerns as occupational therapists is the person's core self, their values, their identity, their volition, all of those things that Professor Kyle Hoffner have mentioned, MOHO. We are concerned about the performance components, the cognitive capability of the person. What's missing? What's the gap? Attention, concentration, recall, problem solving. These are the things that we need to assess and we need to know the state of. Emotional status, we need to remind ourselves of the signs and symptoms, the mood, the affect, all of these things. We need to remember this. The physical status of the patient. Yes, that's good. We've always got somebody to share assessment of those components, particularly the physiotherapists. But we need to rekindle the way we are assessing cognition and emotional components. The other domain of concern of OT is obviously the performance context. ICU setting, that's one. A person being isolated, that's one. Their disconnection from everyday life. If you remember the models like model of human occupation or the MOHO or the KAWA model or even the PEO, which is the person environment occupation, these models, they give us the framework to anchor our understanding even in these highly medicalized environment. When it comes to physical assessment, familiar skills and these new contexts, yes, there is a physical rehabilitation that is involved, but the skills that we bring are not new. They are the same that we use in other settings as occupational therapists. Like, for example, how do we assess? How do we treat? The same skills when it comes to postural control retraining, the same skills as when we have to do general strength retraining, improving endurance, the same principles of biomechanical frame of reference. It's nothing different, guys. What about the muscle tone, coordination, fine motor control? All of these are all common. What makes ECMO different is that the barrier to performance is respiratory. The muscles may be willing, for example, the person's body may be willing, the nerves are firing, it's all there, but the lungs cannot oxygenate the body and it cannot do it well enough to support the activity. And this is what's making the person fragile. So when we are treating patients with ECMO, we as occupational therapists, we should be responsive to how the person is. We should be creative, and at the same time, we need to be cautious as well. The person's alertness, their emotional state, and the positioning capacity, all of these will influence what we can do and what we should do with our clients. For example, a patient may be lying, they may be passive, they may be sitting in a supported chair. They could be alert, but they could be too breathless to speak. They can be confused, overwhelmed, they can be frightened. So, knowing the state, we must design intervention that, number one, promotes engagement even in passive forms. Number two, We should try and think of activities and treatment that should prevent deconditioning, both on the physical deconditioning side and also on the cognitive conditioning side. Another thing is we should restore a sense of agency and the continuity of self, right? Get the person out there through engagement. We can facilitate these things called micro occupations, and it should align with the patient's values, what they like. It should align with their identity. One of the hardest things to achieve in ECMO care is very simple. One word: engagement. Imagine this. Put yourself in a position of a patient who's in ECMO. You can't breathe. Even the slight movement makes you dizzy. You feel like you're drowning, but you are awake. And this is what some ECMO patients feel. Even with minimal effort, sitting, being upright, brushing the hair, lifting their arms, it can feel like they are climbing Mount Everest or any other mountains, right? So engagement should be gently invited, but also we shouldn't be demanding that. You should try it very slowly. It's an art, it's a delicate way on how we can get a person engaging. And often, these small victories, these moments where a person will be alert, even with hand gestures, smiles, little things where they look at you and they engage with you, this becomes therapeutic landmarks. And we look for outcomes. We want to share outcomes. What outcomes matter the most when we are working with ECMO patients? We want to look for outcomes like, did the patient sit up today and the following day and the following day? Did they tolerate 20 minutes being out of the bed? Yeah. Those are the outcomes that we regularly look at. But for OTs, we must also track the narrative outcomes. What did the patient say about the session? After the ECMO, what are the stories? In AOTA, there is a position statement of OT and intensive care, and it says that the outcome can be captured using narrative stories. It's not all physical measurement, because if you're working in critical care, you cannot measure a direct improvement on the physical capability of the person, nor with their cognitive status and their emotional status. Usually, the outcome can be measured way beyond critical care, even after the person's been discharged out of the hospital. And any improvements that's happening out down the line cannot be solely attributed to occupational therapists. So, narrative outcomes is one way of capturing this. What about the psychosocial state? Is the person less anxious? Are they more hopeful? This is hard to capture, but narrative outcome is a way of capturing these. What about their cognitive and emotional endurance? Are they more alert? Are they more responsive? And I want to be honest with you guys, these are hard to measure, but they matter. They do matter. The patient's story is part of the outcome. Their voice, their feelings, their sense of meaning. These are critical indicators of recovery. Clinical reasoning in OT demands that we recognize and we report them, even if they don't fit neatly into a spreadsheet. It's very difficult. So, where do we stand in all of these? We need to understand and we need to recognize that ECMO is not a mystery. It's just one of the context of an acute illness. It is complex. Don't get me wrong on that. It is complex. It's also high risk. But so is traumatic brain injury. So is a spinal cord injury. In many ways, ECMO patients are at an advantage because their brains are often intact. Their cognitions are preserved. The memory is there. The emotional awareness, they're all there. This means that they can engage, they can reflect, they can hope. And again, this is where we shine as occupational therapists. We engage, we enable, we restore. We bring into focus, we bring life into focus. Even when the machines are loud in critical care, the tubes, there's plenty of them, and the air is heavy with technical tension. Doesn't matter. We'll get you going. We have to get the person going. Okay, guys? There you go. I hope you've taken something valuable from this session. If nothing else, I hope it has prompted you to think more deeply about what we do, why we do it, and what we need to protect in our practice. Occupational therapy at its core is a profession of hope. We bring dignity, we bring humanity, and we bring purpose into some of the darkest corners and the darkest continuum of illness. And in ECMO, we have a real chance to actually light a path for patients to return to living and to life. Okay, guys? I initially thought about speaking about competency. Really, don't lose the competency of occupational therapy, particularly in the competency of assessment, problem identification, goal and treatment planning, and implementation. It's an art. It's a science. It's an art, right? Okay. Whew, it's a bit emotional, wasn't it? If you learned something from this and if you like it, talk to your friends about it. Share this. Learn together, grow together over a cup of tea. Just remember, guys, anything you do matters and has an outcome. This is how your occupational therapist, and this is a relevant information involving OT, a riot conversation. Until next time, bye.